Hi, this is Dr. Bernstein with our August 30th, 2017 teleseminar. Before we start, I want to give you our usual warnings, namely that my answers to your questions may not be the proper answer for you, but it'll be an educational answer for the group. It's impossible for me to know your full history, for me to do a physical exam on you, and therefore medical investigation will be grossly incomplete by just reading a few of your words. Therefore, just remember that what I say applies as a general educational scheme for all the listeners and might not really solve your problem. Now, we have two special subjects. The first one relates to the leaks from injection sites that people using insulin pens find. I've discussed this in the past and recommended holding the button down for 10 seconds and then after releasing the button, leaving the needle in place for 10 seconds. But many people still get leakage, but that did not solve the problem. And a listener pointed out to me that the needles that are being supplied for insulin pens are too short. They come in lengths going from 3 millimeters up to 6 millimeters, and a standard insulin syringe uses an 8 millimeter needle, 8 millimeters long. And if you use a standard insulin syringe with an 8 millimeter needle, you're not likely to get leakage. But with these pens, 3 to 6 millimeters, not deep enough. Well, this listener pointed out that there is a source of 8 millimeter insulin pen needles called Easy Glide, and they're made by a company called Global Medical Products. I bought a load on the internet, and they're 31 gauge, so they're very fine needles that don't hurt when you use them. You throw them in fast, as I've instructed in my book. I discovered that Novo also makes an 8 millimeter needle, a 30 gauge needle, which is not quite as fine as the Easy Glide 31, but certainly is acceptable. So there are at least two sources of 8 millimeter needles. And if you're using insulin pens, these are the needles you should be using. The needles that are supplied with the pen are not likely to be adequate. So I use Seba insulin that comes in a pen, and the needles supplied with the pen are all 3 millimeters. So it's hopeless to use them. I got hold of the Easy Glide needles, and they're 8 millimeters, and they're fine. Our next subject relates to the Dexcom continuous glucose monitor. Brand new news that's both encouraging and very disturbing. Medicare has advised the manufacturer of Dexcom continuous glucose monitors that they will shortly be approved for use by Medicare recipients. That means most of our medical population over the age of 65. However, the brilliant people at Medicare have put in a proviso. The proviso is that you cannot have your receiver transmitting to a cell phone. So that means the whole concept of having a follower for someone who has a continuous glucose monitor goes down the drain when it comes to elderly individuals. Is this a prejudice against the elderly by the current administration? Is it sheer stupidity where the people at Medicare who decide what facilities diabetics get don't know anything about diabetes? Is there a payoff? A lot of people have asked me, could there be a payoff, as there has been in the past, both with regard to diabetes institutions and certainly with regard to the government? And who would be doing the payoff? Well, a competitor of Dexcom who doesn't have Medicare approval would very much like the Dexcom approval to be worthless. And one way to make it worthless is to impair the ability to have a follower. It's pretty obvious that people over the age of 65, that many of the people over the age of 65 may need someone on their back, so to speak, if their blood sugar gets too low or very high. I have a follower, even though I'm mentally very agile. I don't want to take any chances on a slip-up, missing a low blood sugar. So my follower will phone me if she doesn't get a signal, and sometimes the signal stops occurring. My sensor gets shifted or comes out, and I don't even realize it. Or she'll phone me if my blood sugar's below my target or above my target. So she doesn't let me get away with not attending to the warnings that the system gives me. And elderly people might be lax when it comes to this, and they need someone to follow them up. So this is extremely important. It's a key to the reason why the elderly should have a continuous glucose monitor. So that's basically the story. Now, why don't I get on the case of Medicare and go after the people who have caused this? Because I don't know who they are. So if out of you thousands of listeners out there have any ideas who at Medicare is making these decisions and how I can contact that person or those persons, please contact me and let me know. And I will be glad to use my influence to try to get this changed. Now to our questions. On Lantus and Humalog, but I want to switch to the Humulin insulins, NPH and regular. What's the best way to do that? I would guess that the best, first of all, I would not recommend anyone switching from a long-acting insulin like Lantus to an intermediate insulin like Novolog. I'm sorry, like NPH. So you don't switch from Lantus to NPH. Makes absolutely no sense. You would have to, where you take Lantus once or twice a day, you might have to take NPH 4 times a day. So I would not recommend that you do this. If you want to switch from Lantus and Humalog to Seba and regular, that's another story. And if you look in my book, Diabetes Solution, you could get some guidelines there. You probably would want to start the regular at about half the dose of the Humalog, because Humalog is twice as potent as regular. But remember that there's room for error, so you might want to lower the regular by 10 or 20% initially till you see what happens. And if you switched from Lantus to Seba, you likewise, their potency are equivalent, So you could try the same dose of Seba as of Lantus, and again, to play it safe, lower it 10% initially and see what happens. What are your thoughts on using a continuous glucose monitor for type 2 diabetics to educate them as to what certain foods affect your blood sugars? Well, I think that's sort of a waste of time, because all you have to do is measure your blood sugar with a blood sugar meter, and that will be more accurate. The continuous glucose monitors lag behind the blood sugar by 20 minutes to a half an hour, and sometimes the results are way off. So you're certainly wiser to use a blood sugar meter, an accurate blood sugar meter. Furthermore, insurance will not pay for a continuous glucose monitor for a type 2 diabetic, and this person apparently is a type 2 diabetic. So it costs you a lot of money and would not buy you much. With the continuous glucose monitors becoming more accurate, do you feel that most, if not all, type 1 diabetics should be using them? I think that they should be used principally to prevent emergencies. I use them really to catch low blood sugars. I don't have very high blood sugars that would be hazardous, but some other type 1 diabetics might. And certainly children who are not following my regimen might. So it's for safety, and I recommend them very highly because emergencies do occur, and this is one way to catch them early before they really become an emergency. Is there a continuous glucose monitor that you would recommend? Although I use a Dexcom, probably all of them are okay, provided they are not tied to an insulin pump. When you have a continuous glucose monitor that may have errors telling an insulin pump what to do, you're asking for potential big danger. And this sort of thing is going on right now. Is there a list of the carbs or other foods that you don't recommend, like corn, etc.? Yeah, there's a list in my book, Diabetes Solution. There's also a list in Diabetes Diet. And for my patients, I have a list that's taken out of my books, and I hand it to them, but it's there in the books. At what level of urine microalbumin and serum creatinine should you be concerned? Well, I would certainly be concerned if it's above the normal range, as stated on the lab report. I would be concerned if it is increasing over time. And I would also recommend that if there are changes in the serum creatinine, you can double check by doing a serum cystatin C level, which is a better indicator of glomerular filtration than is the serum creatinine. Do you still recommend supplementing with selenium if I am being treated for low thyroid? I never recommended that to anybody. I pointed out that one potential cause of hypothyroidism is selenium deficiency. Is it a common cause? Probably very unlikely. And there are potential hazards to excessively high selenium levels in the blood. One potential hazard that I know of is the severity of prostate cancer can increase in people who have high selenium levels in their blood. I believe the ideal level for prostate cancer is between 120 and 150. Selenium supplementation to bring it up to 120 to 150 might be of value. But I certainly have not in the past recommended giving selenium to hypothyroid people. You could check the selenium levels in the blood, and if they're low and you're hypothyroid, you take enough to bring you up to the normal range for selenium. Next question. The A1C test can be the same for two different people because there's just an average over, this person says 90 days, I'd say 120 days. It does not show you the spikes, which can be harmful. Is there a better test? Yeah, the best test is blood sugar self-monitoring. You could supplement that with continuous glucose monitoring, which has potential errors, but you double check it with the self-monitor or the blood glucose meter. And if you follow my book, Diabetes Solution, you should have far fewer spikes than you're currently experiencing. The whole point of the book is to have level blood sugars, not spikes, or not up and downs. My dietitian says I should do a glucose test 2 hours after the start of a meal, or should it be 2 hours after the meal is finished? I don't think it's going to make that big a difference, and it depends what you're looking for. I recommend when I'm initially starting a patient on a new regimen that she check 1 hour and 2 hours after the end of the meal, and I want to catch the highs and I want to catch the lows. That might not be enough. Might have to do it every hour for several hours if you want to see what the result will be. Now, at the beginning, when you're trying out a new regimen and a new meal plan, it's wise to do frequent blood sugars after meals. But once you get worked out what insulin you take for what meal and how long you wait after you take the shot, you should be pretty flat thereafter, and then you don't have to be checking frequently. So this dietitian, I suspect, is giving the patient different meal plans. Well, I should put it differently. My recommendation is that you eat the same food for breakfast every day, the same food for lunch, and the same food for dinner. Not breakfast, lunch, and dinner don't have to be the same as one another, but for a given meal, it'd be the same every day, so you know what your insulin dose should be, you know what the timing should be, and it's not a mystery from one day to the next. Unfortunately, too many dietitians advocate the ADA regimen where you eat whatever you want and then guess at the insulin and guess at the timing, and that ain't going to work. Do you ever recommend intermittent fasting to decrease insulin levels for type 2s and obese patients? Well, I don't know what intermittent fasting means, whether you fast for a day or a week or a month. And if fasting means not eating. If you don't eat for a day or longer, you're going to lose fat and muscle. And then when you start eating again, you replace the fat first, and it takes longer to replace the muscle. So it's not a good idea to be fasting, especially if you're cutting out protein. Now, if you want to eliminate the carbohydrate, that may be reasonable on the one hand. On the other hand, our regimen allows so little carbohydrate that you're eliminating almost nothing. So I would say that this fasting business is a myth. There are so-called experts all over the world advocating all kinds of special fasts, and the net result is that people lose weight and after the fast start gaining fat. Is there a relationship between type 2 diabetes and AFib? AFib is atrial fibrillation, and there are all kinds of cardiac conditions caused by high blood sugars, prolonged high blood sugars. So one can say that, yeah, type 2 diabetes could be a cause, but it's the high blood sugars over a long period of time that could be the culprit. But there are many other causes. So that's the best I can tell you. Since you switched from Lantus to Seba, do you recommend those on Lantus or Levemir to switch for better control? You had great control with Lantus. Why switch now? Well, first of all, how does this person know that I had great control? I had good control by my standards, but this person doesn't know that. And the reason I switched was because I had to take a shot of insulin. Actually, I was taking a shot of rapid-acting insulin on a rising to prevent a blood sugar increase from the dawn phenomenon. I've eliminated that with the Seba, but I still have to take my Seba at about 4 o'clock in the morning, so it's not an ideal solution. I would much prefer if I could take it at bedtime. It happens that I get up in the middle of the night to pee anyway, and if the time is near 4 a.m., I'll take my Seba. But it's not a perfect situation. But it is better than when I had the Levemir. You mentioned that you can identify long-term diabetic by their puffy eyes. Can you explain what causes the puffy eyes? Is it a sign of neuropathy? Well, I did not say puffy eyes. I said droopy eyelids. And this is, and as I explained when I said this is due to a neuropathy of the levator palpebrae muscle that lifts the eyelids. So the nerves that, the cranial nerves that cause the eyelids to lift are affected with neuropathy, and the eyelids are weak and they droop, not puffy. Granddaughter diagnosed 12 weeks ago with type 1 diabetes. Is whey protein powder a good way to get more protein into the diet? A scoop provides 18 grams protein and only 2 carbs. Yes, whey protein is reasonable. I guess some small kids may not want to eat a lot of a protein food at a meal, might be too filling. Of course, if you give them multiple small meals, which is one answer to the problem, you have to give multiple injections of rapid-acting insulin, one for each meal, and you also are unable to give corrective doses of rapid-acting insulin for high blood sugars if the meals are spaced too close together, because the insulin taken at one meal is still working when you're ready to do a correction, and it may yet drop the blood sugar. So you have to wait and only give shots once a day in the morning when the kid wakes up. That makes things sort of hard. So using whey protein to increase the protein at a meal might be a very good idea. It's something that I should have thought of, but I don't think I've mentioned that. We do use protein powder for treating gastroparesis, because we put it into a liquid and the liquid goes down better. Recently encountered on BD and Reliant brands of insulin syringes that the 0 mark is at the 1/2 unit from the plunger when pushed all the way in. Have you encountered this, and what would you do to ensure accurate dosing? I would say that you may be looking at the wrong part of the gasket at the end of the plunger. If you look at the part of the gasket, the black rubber gasket, that's furthest away from the knob at the end of the plunger where you push, that's what should be at the 0 mark when the plunger is all the way down. And indeed, it is there. If you look at any other part of the gasket, it will not be at the 0 mark. I enlarge this. You can take your syringe and put it on a copy machine and set it to magnify 2 power or 4 power, and you can see very clearly that the plunger is in the right place. On average, from your personal experience, have you seen more or less cancer with your patients that have normal blood sugars? I haven't seen more or less based on blood sugar, but in those with CVID, common variable immune deficiency, I've certainly seen more cancers. And with those who have low IgM, a particular immunoglobulin, there seem to be more head and neck cancers. So, and we do know that CVID affects 25% of diabetics. It's interesting that the ADA refused to publish this, but I guess my publications are anathema to their guidelines. Next question. What kind of lifespans have you seen with your patients that maintain normal blood sugars on a low-carb diet? Well, I got a call about 2 months ago from a patient who retired to Florida and called me to tell me it was his 95th birthday, and he wanted to thank me for everything I had taught him. And I had treated him last, I guess, 15 years ago, maybe 20 years ago. So he lasted, he's still alive at 95. I'm 83. I'm trying to think. I do have a number of patients that I've been treating 20 years or more that are in good health, don't have cardiac disease, don't have strokes and so on. But I have no statistics because I haven't been, there haven't been enough patients that old. I've been a type 1 for 23 years and I have the poked up sore fingers to prove it. Do you know of anything out there I can use to test somewhere besides my fingers that won't hurt so much? Well, first of all, you should read my book, Diabetes Solution. It tells you to use, how to use other sites on your fingers other than the fingertips. And I go all the way around my finger. I do the side with the nail, the lateral sides, also the fingertip. I do along the length of the finger. So you can spread the finger pretty far, but it doesn't have to hurt. First of all, I would recommend that you get the Gentile Butterfly Touch Lancets that I've been recommending. I also would recommend that you use the True Draw lancing device that I use because it can be adjusted to give you just the right depth of puncture. I guess that's about it. In reference to a statement at the bottom of page 178 in Diabetes Solution, if blood sugar increases by more than 10 milligrams per deciliter after a meal, are you referring to the 2-hour postprandial reading or any higher reading during that 2-hour time frame? Talking about any reading. Can you squeeze your finger to elicit a blood drop for glucose reading, as I need to squeeze hard to get a drop? Well, depends how hard. If you really are milking the finger, you're going to add some interstitial fluid to the blood. The interstitial fluid has glucose in it, but as you know from the continuous glucose monitor, which measures glucose in interstitial fluid, it runs 20 minutes to 30 minutes behind whole blood. So if you dilute the blood with interstitial fluid, you're going to get a slightly different reading. And how do you arrange to get better blood flow? One thing you could do is you could stick your hands under warm water before you puncture them, and warming them up will help. You could get the Gentile Butterfly Touch lancets and the True Touch lancing device, just like I mentioned earlier. All of those will help. The warm-up will certainly help. Type 2 on metformin for 3 years. Recently noticed my blood sugar is taking longer, 3.5 hours, to return to a normal range after meals. If I eat low carb, I get a spike at 128 milligrams per deciliter. I tested with a small bowl of oatmeal and got a spike of 170. But the strange thing is it took the same amount of time to return to my normal range. Endo suggested a sluggish liver. My guess is that over time your beta cells may have been slowly burning out because you probably have had high blood sugars. If you're eating oatmeal, you're consistently having high blood sugars, and that's going to foster beta cell burnout. Ideally, if you're eating right and taking the right combination of medications, your blood sugar shouldn't increase after a meal at all. But you may need injected insulin before your meals. I have many type 2 diabetics who do take injected insulin before meals. Some of them are on very tiny doses, but you do what is necessary to keep the blood sugar normal, and you certainly don't eat oatmeal. Type 2 diabetic. Blood sugars are odd at times. I follow your program pretty close. but as you'll hear, not really as I state in the book, in my book. I was on metformin and glipizide, which I recommend against in my book, so he's not been on my regimen. Recently, glipizide removed. Have some peripheral neuropathy of numbness in toes and front part of my feet. I wake up and have 104 blood sugar, then it rises during the morning. As I don't eat breakfast and eat only lunch and dinner, even when I eat breakfast with 1,000 milligrams metformin, it does not lower my blood sugars within 2 hours after eating. Same happens with exercise. Blood sugar goes up. So again, just like the prior question, this guy's had high blood sugars. That causes beta cell burnout, and he may well need insulin to cover his meals. Type 2, 1,500 milligrams metformin, ER, that's the long-acting one. Even when my blood sugar is under 100 the whole day and in the 70s to 80s from 11 a.m. to 6 p.m., I often have a spike of 90 to 110 at 7 p.m., then drops rapidly by 8. Do you know of what reason for this evening spike? It occurs even after a dinner of 5 ounces protein with less than 10 grams of carbs. Now, if I did not take insulin to cover my dinner, which has about the same amount of protein as carbs and the same amount of protein and carbs as he does, my blood sugar would go up by about 230. Would increase not to 230, but by 230. So if I started off at 80, I'd be 310 because I don't take insulin, if I didn't take insulin for dinner. So this person probably needs insulin for dinner. Metformin is not a substitute for insulin if you need it. Also, one reminder to all these people who are taking metformin, and that is that generic metformin, according to my experience, is far less potent than the brand name glucophage. So I only prescribe glucophage for my patients, and in my experience, the generics were running half as potent or less than the glucophage. I'm a type 2 and have my BG under control, usually around 90 to 100 in the mornings. I eat to the meter and rarely go over 120 post-meal. I also rarely have carbs and sugar. However, I occasionally crack and treat myself to cookies or bread. Is this once in a while spike of blood sugar harmful? Well, aside from perhaps slightly increasing the risk of diabetic complications, it also is going to foster beta cell burnout. And if one of the complications is gastroparesis, it's going to make it much harder to control your blood sugars. So it probably isn't a good idea to be having the cookies or bread. What are optimal thyroid levels? Free T3, free T4, TSH. And what are the optimum levels once you are on thyroid medication? First of all, the lab report will show you the normal ranges for these tests. I do not routinely check TSH because it does not reflect actual activity in the body. It reflects the level of T4 in the pituitary, and that doesn't relate to how people feel. People can have a high TSH, which would suggest low thyroid, and yet be symptomatic of hyperthyroid and a low TSH, and be symptomatic of hypothyroid. So to test for something that has no relation to symptoms, I'm reluctant to do. So I won't even discuss the TSH. The others, I looked for the midpoint of the normal range. Now, that might be simplistic, but it's the best we can do. Different tissues have different rates of absorption of thyroid hormones from the blood and will respond differently to a given blood level. We can't correct for that. We don't know how. So the best I can suggest is you pick the midpoint of the normal range. My doctor here in France has prescribed for me Toujeo Solo Star insulin Glargine, which is U300 Lantus insulin, by the way. And I might point out that it was developed to ameliorate the ADA and their high carbohydrate diets. As you know, basal insulin is frequently inappropriately used to cover meals, as well as the basal state, the fasting state. And if you give people a lot of carbohydrate, they're going to need very high doses of insulin and big injections that leave big lumps. So by making a U300 insulin, the lumps go down to 1/3 the size. In any event, he says, it has a leveling off effect on my blood sugar and keeps it either constantly high or constantly low. Are you familiar with this kind of insulin, and would you recommend it? I would certainly. So basically what the doctor in France is doing is giving him a high carbohydrate diet and having him take a very powerful long-acting insulin that forces him to eat all day long to cover the insulin, and it never works. You can't possibly have normal blood sugars. So I would suggest that the patient and the doctor read my book, Diabetes Solution, and embark upon a more reasonable insulin regimen, namely a basal bolus regimen of the type that we recommend in my book, and also low carbohydrate diet. There are 90 million people with diabetes. Would you recommend your program for this group? Why not? I'm sorry, I read this wrong. 90 million people with prediabetes. Well, with those with prediabetes, those who are diagnosed with prediabetes frequently have diabetes. For example, they'll say that someone with an A1C of 5.9 is pre-diabetic. Well, that's an average blood sugar, an average of 136. To me, as a physician, I would treat that patient as if he were diabetic, and I would do whatever is necessary to get his A1C down and to get his blood sugars all around 83 milligram per deciliter if it's an adult. Now, if they're pre-diabetic based upon genetics, that is, they have family who are diabetic, or the patient is overweight or physically inactive, if there are other reasons than A1C and blood sugar for calling him pre-diabetic, then I'd recommend diet, exercise, if necessary, weight loss, and even there's always the possibility of even using things like glucophage XR, which lowers insulin resistance and can facilitate weight loss. Also, for some people, reduces appetite. How important is it to eat 3 meals a day if you have type 1 or type 2 diabetes? It depends on a lot of situations. It makes possibly for more even blood sugars, but not necessarily. For example, I am too busy to eat lunch. I just don't have time. and I don't have a huge breakfast and I don't have a huge dinner. The size of my breakfast is about the same as dinner, a little bit smaller. I'm not a big eater, so I don't have blood sugar rises that exceed the capability of my insulin use, so I can get away with it. But if someone is a big eater, it pays to redistribute their food over smaller meals. And this is especially true and mandatory if you have gastroparesis. If you have gastroparesis, stomach emptying is impaired, and the more you eat, the more trouble you're going to have, because you'll have more unpredictability of stomach emptying and more unpredictability of blood sugars. So for gastroparesis, it's mandatory. For kids, it would be mandatory because they're going to get hungry in the middle of the day, and taking away a meal is going to leave them hungry. Otherwise, it's a matter of individual situations. Have you seen patients with type 2 diabetes who have followed your program and were able to prevent diabetes? If so, are they still diabetes free? Well, I only know of one case, and he was not my patient, he was a friend, and I've referred to it over and over. He had gained 100 pounds and got his pharmacist to give him insulin and syringes without a prescription. In those days, you could get away with that sort of thing. It was a long time ago. It was before I became a physician. And I sent him to a physician who was able to put him on a low carbohydrate diet so that he lost 100 pounds. And he was able to go back to his old suits, stop the insulin, and according to what he told me, the diabetes went away. Did it really go away? I don't know. So I have not treated any type 2 diabetics and made their diabetes go away. By the time they come to see me, they usually have been diabetic for long enough to cause a lot of beta cell burnout. I'm 70, female with type 2 diabetes, A1C 4.9, and on your diet for 4 years. When I restrict carbohydrates to the level you recommend, I lose weight. Usual weight is 120, I go down to 114. Doctor encourages me to eat more protein, but I already eat so much protein that I lose my appetite and skip meals. Do you have any suggestions other than eating more protein? I'm getting discouraged. Well, what I suggest is what your doctor suggested, but you could make it easier by having protein shakes. They're much more tolerable, less filling, and I would suggest that you either use the whey protein shakes or the egg white protein shakes. Some of them are already flavored. Some people like the flavoring. Other people find that the flavoring's not strong enough, and you could add Walden Farms sugar-free maple syrup or sugar-free caramel syrup, which are strongly flavored syrups that can add more taste to the shakes. Or you could add Da Vinci syrups, which are in maybe 36 different flavors, but not as strong, so you'd have to add more of the syrup to the concoction. But that's what I would recommend, protein shakes. Type 1 on insulin, 48 years, good control with split Lantus dose. Should I switch to Seba? Cause less concern regarding carcinogenic possibility of Lantus. Well, until today, I would have said yes, and also because it gives a smoother profile. But there was recently a report published in Diabetologia, just came out today, where they compared Lantus to Levemir, and they did find differences in cancer incidences for specific cancers at certain numbers of years. They followed up, I think, every year for 6 years or longer, and but these were sort of haphazard increases, and there were also increases in the Levemir, so that the net result was a washout where they couldn't really find a statistical difference between the two. Now, was this study potent enough? I think we're going to have to wait to hear opinions of people more familiar with medical statistics than I am. It could be that the Lantus scare was just a scare. But remember that it does have 165 times the affinity of insulin-like growth factor receptors than does human insulin. So that does worry me. And we'll see what the commentary is on this particular study. Although there were about a dozen authors of the study, and their affiliations were stated in the article, there were no statements of consulting fees or income from other sources than their employers. And the employers were not manufacturers of insulin. So we don't know if they were receiving payoffs on the side. I just submitted a paper for publication. I had to state that I get royalties from book sales. So I'm just not certain. Type 2 pre-diabetic, waking blood sugar 100 milligrams per deciliter, drops to low 80s from cold shower. Why does this happen? I can only speculate. By the way, I don't know. Well, I guess we would call her pre-diabetic because her fasting blood sugar's fairly high, 100 milligrams per deciliter. Now, if she's taking a cold shower and shivering, that muscular action could lower her blood sugar. In fact, I remember years ago when I used to have my telescope outside, long before I became a physician. I would take astrophotos through my telescope, and I'd be sitting out there or standing out there for maybe an hour, and boy, my wife used to drag me in to check my blood sugar, and it would always be low just from standing out there in the cold and shivering. So I learned that every 20 minutes I had to come inside and check a blood sugar and correct it. Type 1, recently tested my blood sugar with a Freestyle light. 3 readings, same time, different fingers. Readings were 51, 69, and 61. I have had other issues with this, trying different batches of strips and different Freestyle meters. Do you know of any changes in Freestyle's quality protocols on why this could happen? How should you react to these readings? Well, first of all, if they were say 51 and 61, I wouldn't be surprised, but this is more than I usually see. Now, it happens that low blood sugars and high blood sugars are out of the linear range of these strips. A dose response picture is S-shaped. Low end, linear in the middle, high at the high end, it's at the top curve of the S. So you could have at the low end a big change of blood sugar and only a small change on the strip, and at the high end the same thing. And none of the meters on the market are really accurate at the low end or at the high end. The Freestyle meters, in my experience, are accurate in the normal range, and I would consider the 69 close enough to the normal range for it to be pretty accurate if your blood sugar were really 69. That's the best I can say. Even the Freestyle is inaccurate as you get above 120 milligrams per deciliter, and likewise as you get around 40 or 50. But if you're around 40 or 50, you're going to deliberately overcorrect to play it safe, and you're going to check your blood sugar frequently after you make the correction. And if you're above 120, you should go on my regimen to try to keep your blood sugars less than that and not be overeating. My 14-year-old recently diagnosed follows your protocol using regular insulin. Tends to have elevated blood sugars before lunch and probably due to the dawn phenomenon. Probably due to the dawn phenomenon. He is scheduled to do physical education in the mornings when he starts school. In the past, his blood sugars tended to go down slightly after 40 minutes of exercise. But if the exercise is strenuous, they go up after exercise, and then a few hours later his blood sugars drop. So what do you recommend he get his exercise in school? Well, first of all, according to this parent, the child's not getting any basal insulin, so he certainly needs basal insulin. I would strongly recommend that the parents read my book. Even the son should read the book. And I would think that he should get twice a day Seba insulin. And furthermore, I'd recommend that whatever physical exercise he's getting be done in the afternoon, so it's not likely to be affected by the dawn phenomenon. Then, once you've done all these things, you take a look at it and think about what to do next. It may not be necessary to do anything, although it might be necessary to check blood sugar during the exercise and take liquid glucose if it goes too low. Next question. I understand that achieving normalized blood glucose levels involves the blood glucose being at the target of normal, around 83 after a meal. How long after a meal? Here we go with the same question as before. It should be 83 right through. 1 hour, 2 hours, 3 hours, half hours, and that requires careful adjustment of the contents of the meal, the timing of pre-meal insulin, and the amount of pre-meal insulin. This is how I spend my life with my patients. They email me their blood sugar data sheets, and these are new patients, and we have to figure out what regimen is going to work for each meal. How do you work with type 1 patients who work unusual shifts? It has always been my practice to advise patients against rapidly changing shift works, but looking for more guidance for this. Is there generally recommended period of time between shift changes that anyone would advise in the interest of the patient adjusting eating schedules and insulin doses in order to maintain control of insulin-dependent diabetes. I think that the problem is really sleep, that people who have shift changes have difficulty sleeping. And I haven't had blood sugar problems except when where we have physicians who may be working at night in the hospital when the cafeteria is closed and he's not able to get food. Then that relates to his diabetes. But the most common problem, according to the literature and also according to my patients, is being able to fall asleep when you're going from one shift to another. And some physicians have protocols where they use melatonin at certain times of the day in certain doses to facilitate falling asleep more easily. Do you ever recommend type 2 drugs off-label for your type 1 patients, like a DPP-4 SGL2 inhibitor? Well, yes and no. Certain of these products have problems associated with them. The GLP-1 agonists are very helpful in controlling appetite, and I've used these a lot for type 1 patients. One problem is that over time, many people become tolerant to the appetite effects. The effects directly on blood sugar are quite small and minuscule in comparison to injected insulin. So that's not a reason for using them. The SGL2 inhibitors have such a wide collection of adverse effects in my experience that I'm loath to use them. I avoid using them. I find that they accelerate dehydration, that patients then get all kinds of symptoms of dehydration. I've seen people who never had urinary tract infections get urinary tract infections, et cetera, et cetera. The DPP-4 inhibitors don't seem to have as much of an effect on appetite as the GLP-1 agonists. They theoretically increase the level of GLP-1, but in practice they have very little effect on appetite, and they do have their own set of adverse effects. And until recently, there were some indications that they increase the incidence of heart attacks. So, on the other hand, glucophage or metformin has been helpful, and also Avandia have been helpful for type 1 diabetics who had polycystic ovarian syndrome, also for type 1 diabetics who are menstruating and get unpredictable blood sugars the week before menses. Here, the metformin, I should say the glucophage and the Avandia can be very helpful. I have some people that just have, especially growing children who have erratic blood sugars due to growth hormone spurts, and they do better when we give them glucophage and even Avandia. So there are special situations where certain oral agents can be of great value. What is the best way to correct for the dawn phenomenon prior to eating breakfast? Well, the two things are to take Seba insulin at bedtime, and maybe your second shot very early in the morning, before your usual wake-up time. And another thing that I do with a lot of people, including type 2 diabetics, is giving them diluted Humalog on arising. It works rapidly, and although pure Humalog is too potent for many people, you could use pure Humalog for very obese people who are insulin resistant, and for people who are slim, you might want to use diluted Humalog on arising to offset the dawn phenomenon. Well, that's it for tonight. Our next teleseminar will be Wednesday, August 24th. Look forward to seeing you then. Thanks for listening.